Thank you very much. It's great to be talking about adolescents in a forum like this, but I'd like to take you back, and for the rest of your working life, you have a choice of 3 age groups. You can work with 0 to 10-year-olds, you can work with 10 to 19-year-olds, or you can work with adults. Please raise your hand if honestly you're going to choose the rest of your working life to work with 10 to 19-year-olds. Remember, you're in an adolescent forum, so some of you have got to show some enthusiasm, okay? Well, that's quite honest, because if you ask healthcare professionals, particularly those who are adult-focused, only about 1 in 10 wants to work with teenagers and young people. The rest of them are absolutely terrified, okay? And that's the issue with transition. And you have to remember that transition is a process, and it's a process that spans years of life. And it's not just about health. It's a much more holistic, multidisciplinary, it looks at education, it looks at your social setting. And why do we talk about transition? Well, if you look outside of HIV, what we see is if you go through something as a child as serious as a renal transplant, within a couple of years after transferring to adult care, if your transition isn't well managed, you'll lose that graft. When we look at HIV, it is pretty much a data-free zone, okay? There's quite a lot of data emerging on perinatal adolescent health outcomes, but that's not the same as transition, okay? So actually, what we really need to look at is how, going forward, are we going to find the best way of transitioning in different global settings? And there really is no data on that. And obviously, it is going to be setting dependent. Okay, if you're in KwaZulu-Natal in a primary healthcare setting, you're not going to have transition in the way that you're going to have if you're in a tertiary healthcare setting in the UK or the US. But that may be to your advantage, because if you never have to transfer your healthcare setting, all that needs to shift is the approach that the healthcare providers give you. From talking to your parents as a younger child to shifting towards talking to you directly. The red arrow is there, the sort of zigzag is to remind me of my sort of specialist children's hospitals that geographically separated were set up for children's diseases before they survived into adult care. And actually, I think some of the most difficult transitions are from specialist children's hospitals. And what do we want to achieve at the end of transition? What do we actually mean? What is the end result? And that's a young adult who has the knowledge, the confidence, and the life skills to manage their HIV care. And that is a very long process. And it has to be tailored to within your individual setting, and indeed to within that individual child, young person, adolescent. And remember, this is a transition that not only is there for the young person, but is also there for the family, okay? And all this is going on in the middle of a huge transition, okay? Adolescence and into young adult life is an incredibly exciting time, but it's also an incredibly scary time. And on top of all the changes in your life that are listed there, and that's a way we use to take an adolescent history when we're teaching medical students. And I just draw your attention, those of you who mainly work with horizontally infected adolescents, I think that going through the whole of your sexuality, if you drag your own minds back to your first ever sexual experience, but doing that with a stigmatized sexually transmissible disease before you've actually really worked out your own sexuality or had sex yourself, makes it a very complex situation. And so we're asking adolescents to go through all those changes with HIV on top. And then we say to them, oh, and it's a really good time to move your healthcare as well. Okay, and we wonder why it's a complicated, most of us would find that a very complicated situation. So, it's not surprising. Some of us in this room, probably some of the pentagroups certainly have refused to grow up and are still stuck in their adolescent phase, and maybe that's why they quite like teenagers. If we go to the UK, well, over 60% of the kids ever diagnosed with perinatally acquired HIV infection are now over 16. They are growing up. This was a snapshot of our clinic database. And I know it's difficult to see, but on the top corner, you start at 31. That's our oldest with perinatal infection. And I went down to the sort of 19-year-olds. And in yellow, I just highlighted those who were on my hit list. Okay, that may be because you have a CD4 count of 10. It may be because you've been suppressed for 15 years and have a malignancy. And potentially what we can see is that the column where you start off at 31, appears to have a few less worry lines. And this sort of made me very optimistic, and the study that's listed above actually showed that glucose control in insulin-dependent diabetics, whilst it gets worse through the teenage years, once you get to 18, it then seems to improve. And I thought, well, maybe we see this with HIV. However, I thought again, and I thought actually if I put the 3 young people who unfortunately have died in our clinic in the last 5 years, all 3 from non-adherence, actually the yellow bars would be in the 26, 27-year-olds. But maybe it's a sign of optimism. When you look at the outcomes of transition, there's virtually no data at all. Okay? The top study is just a description of 11 deaths that occurred in the UK in adult care of perinatal infection. I think we wouldn't be surprised to see that there are 2 suicides, that all of them had a treatable virus, so none of them had a multi-drug resistant virus that was untreatable. Some of them required complex regimens, but that 9 out of 11 also had an additional mental health diagnosis. And we look from the States, the loss to follow-up. This was looking at a cohort when they turned 21 and then a snapshot after turning 22 when in adult care. And, there was a loss to follow-up rate of nearly 20%. And that was associated with being in an adult versus still being in your pediatric service. When we look at kids in the UK moving out of pediatric care, this is a snapshot at the time they move into adult care. We see that 72% have an undetectable viral load. And what we don't have, but we will have, is looking at that cohort data. So in pediatrics, you're followed up prospectively with annual reporting in the CHIP study. We have great data in the UK. And very recently, we've now got funding to continue that. Jeannie Collins and Ali Judd at the MRC doing a CHIPS Plus. So we should have the long-term outcome data following transition that is so lacking. This is what we do in our service. We have a family clinic. You can't start transition until you know your HIV diagnosis, so that naming. We then focus on transition from that time, and then you move towards our young adult clinic, or you can go to your local adult service. The majority come to our young adult clinic, which is called the 900 clinic. You tend to move at about 17, and this is an adult service. Okay, and it was set up in 2006 when we realized that those kids who were moving out of pediatrics were just disappearing into the ether and not taking up adult care. But it's an adult service. There is an adult doctor, there's an adult nurse, adult psychologist, adult dietitian. I am the only imposter, okay, because I started life as a pediatrician, and then Graham Taylor, who's in the audience, suggested some of us in pediatrics had to learn about sex. So somehow it was nominated for me. And he'll explain any questions for that. And, but what we decided was it's easier to transition the pediatrician, okay, than the kids, all right? And ideally, when the service was set up, they said, okay, at 25, all the young people have to move on into the main adult service. But actually, what we've realized is that actually they can stay. This is an adult clinic. It's got an adult doctor, adult nurse, adult psychologist. It just happens to have this weird sort of pediatrician person, okay? But that's sort of fine. And actually, I think increasingly we have to look at the perinatal cohort. By the time they get into this clinic, they've had HIV for 20 years. Okay, if you took an adult cohort that was HIV experienced for 20 years that started in the pre-heart era, they would have similar levels of complexity. Okay, so we've now sort of moved on to looking at a sort of lifelong follow-up for perinatal. We also have some horizontally infected vulnerable adolescents. And this is why. It's seeing, we're into the 4th decade. We've got, young people who are now getting into their 30s. And it's seeing the late effects, so the non-cirrhotic portal hypertension. This is an MRI of a young man who's been suppressed, had tenofovir at age 6, about 15 years ago. Okay, so was the first European kid to get tenofovir because he's Hep B and HIV co-infected. And he's been suppressed for, years and years, and has recently had a hepatocellular carcinoma. But also within this clinic, I don't think you can talk about perinatal HIV infection without acknowledging the neurodevelopmental consequences, and that there are a proportion of young adults with perinatally acquired HIV who are vulnerable, who do not have the capacity to consent to complex healthcare decisions. And that, I'd like to tell you, is the histopathology of his HCC. Actually, it's not. It is the ice flow as I flew into Canada 2 days ago, but I realized I had nothing for Canada. And to me, it looked like histopathology, because I'm not very good, but it looks like fat cells. Okay, I want to tell you a story, because I think for me, I always learn through sort of clinical vignettes. So this is a young woman adopted from Romania in the pre-heart era, never suppressed, had a gastrostomy tube for adherence that we've heard about from Rachel, for 5 years, fully suppressed on a gastrostomy tube. Was a teenager, 15, didn't want a tube stuck in, wanted a boyfriend, tube taken out, she disappears, 6 months, comes back, already been pregnant, had a miscarriage, comes back with symptoms of PID. This was 2006, just as we were setting up the clinic. So what we did was we shipped her into the 900 clinic with the paediatrician. It wasn't really a transition, it was a transfer. It was sort of mass panic. How can you have somebody pregnant in a pediatric clinic? This is just to remind me that actually, for young people who are perinatally infected, onward disclosure is a different phenomena, because you're disclosing not only your own status, but that of your parents, of your dead brother, of your father potentially, and it is much more complex. And I think we have to be very aware as healthcare professionals that there's increasing evidence that the way we name HIV to children is the way they mirror their onward disclosure. So think very hard about your process about naming, because that is their only experience when they have to tell their first sexual partner. Anyway, she disclosed to her partner, he wanted a kid, she wanted a kid, so they had a kid, she took her antiretrovirals. But being a teenage mum is tough. She stopped her antiretrovirals soon after he was born. He was HIV negative, she was undetectable at birth. And despite a lot of support, including from her partner, she found it very, very difficult. And in the end, ended up having a peg reinserted and a very lovely community nurse coming into the home to give her antiretrovirals, who off her own bat decided that this young mum, who was an orphan, who had no parenting model herself, that she had changed the time she came into the home to give the meds to encompass, to the early evening, to teaching her about how do you put an active toddler to bed if you've had no role model and you have no family. How do you do that? So she took her meds and she gets lipodystrophy. And the pressure on young people from society to have the perfect body image when you're going to give them antiretrovirals that do that is enormous. That sort of little cloud is to remind me, I was brought up in a very traditional way. You always took the pulse of your patient on your right-hand side. I now only take the pulse on the left because the majority of particularly teenage girls are right-handed. They cut onto their left forearm. Now, if you're going to go looking, you have to be prepared to continue the conversation afterwards. And without that, you cannot think about transition without thinking of the mental health. And certainly in the UK, we see about a quarter of the young people have formal psychiatric diagnoses, and we're going to hear much more about this in a sort of age-matched Alfie cohort from Martha later. But the risk factors for HIV mirror the risk factors for adolescent mental health disease in most settings. It's the same vulnerable populations. And some of those risk factors involve the sort of risk behavior taking. And I think lots of people think these kids have gone through puberty late, they're looked after by lovely cozy pediatricians that wear sandals, and they're really cute kids, and they're not going to do anything wrong. They're certainly not going to have sex. If you're in the UK, nobody has sex in our clinic. They get pregnant, but pediatricians we haven't worked out. But there is very good evidence that children and adolescents with chronic disease, and this is not just HIV, but it makes sense to me that you go out and you take risks and you experiment a bit earlier, okay? Because your assessment of risk is different. If you've always lived with something that might kill you, you assess risk in a very different way. But, you know, we hear a lot of bad about teenagers, okay? They get an incredibly bad press, okay? And actually, they don't do anything worse than adults. They're possibly just a bit more open about it. But, you know, they sort of do the same stuff. But they have an excuse, okay? In that your prefrontal cortex, which is what experience and reasoning and all that fine pruning that goes on, that continues into your mid-20s, okay? Any of you that are over 25, it's just sort of downhill from there on in. But up to 25, and there is evidence from, you know, SPECT scanning that teenagers born with HIV, that maturational process, even in those who have a normal IQ, is actually delayed, that those neuronal connections and the inflammation, the cytokine storm that goes on with HIV, that process may be delayed. So if we go back and take that into context and looking at transition service models, well, there is no perfect model in any chronic healthcare disease. There's virtually no data, which is why I've told you a few stories and not presented any. There's a massive amount of guidance and opinion. Most of it actually pretty good. There's no money in it. But, you know, they are going to be in care, in your care, and then in adult care. And if they're not in your outpatient clinic or your adult colleague's outpatient clinic, they're going to be in your wards. Okay? So it's how best to care with them within a resource-limited setting in every way. So that's examples. You know, let's start off. What do teenagers want? You know, they don't want to be in your clinic. Okay? They don't want to be coming to see you. And if you're that 9 out of 10 healthcare providers who are petrified of teenagers, they have interviewed you in the first 20 seconds and put you in that box as not interested, doesn't understand me, doesn't want to get me, wants me out of here with the anti-rets very quickly, that I'll just put in the bin. Okay? They are very busy. Okay? You are not busy compared to the average teenager. Okay? Don't laugh, it's true. They have so much going on. So they want their HIV care, their medical care, they want their contraception, they want their vaccinations, all in one-stop shop. Sending them somewhere else, go ask them to come back for a day. They've got no money to travel. They've got no text. They've got no credit on their phone, so anything but text. You know. But what do they want of you as a healthcare provider? Well, they want what we want of our healthcare providers. They want someone who's competent. They want someone who sort of cares. That would be nice. Okay. They want their confidentiality kept. They do not want to feel that the next person in the clinic is their mother and you're going to tell them everything. I think, you know, when we're looking at transition programs and engaging adolescents, this is quite an interesting. This was a sort of a program in the States that was looking at cystic fibrosis, inflammatory bowel disease, but a whole load of different chronic diseases of adolescents, and looking at using technology, so an internet-based site, looking at using web-based sites. We use a lot of text. Okay, I don't really ever phone a young person, and if they get a missed call from me, they text me back going, "Caroline, no credit." You know, sort of. And I think, you know, using adherence apps, using alarms, text reminders for clinic. Every time I change meds, I make them take a photograph on their phone so that when they drop the pills, drop the Dosset box, they can refill it from that photo. And when they see the next healthcare provider, they can just show them the photo when they don't know the names. So I think modern technology, teenagers are so good with it. I usually hand them my phone, then they sort it out for me. You know, this is the latest person. That picture is me drawing. I hope you like my moon and my sun. This is not good news. This is the latest outside referral to our young persons clinic. He's 30. He's got autism. That is twice daily darunavir, ritonavir, dolutegravir, and combivir. He's got 5-class resistance, if you include the fact that he's exfiltropic. He's 30. He doesn't have capacity to make healthcare decisions. He was only diagnosed 4 years ago. Both his parents died in the 90s. So in social care with directly observed therapy in 4 years, he's run through 5 classes of antiretrovirals. So to improve the situation, what do you need? Well, as paediatric healthcare providers, it's our responsibility to go and find our adult colleagues who like teenagers. So you're hunting for that 1 in 10 that genuinely like teenagers, okay? They don't all look like ET. Some of them are quite personable, you know, so you just have to find that person. Maybe you don't have to get that close to them, but you need a cordial relationship with your adult colleagues, or even closer than that, okay? Yeah, I'm not the queen. So what works? So to do joint clinics, and it doesn't matter whether it's the nurse, it doesn't matter whether it's the clinic manager, it doesn't matter whether it's the peer support person, but that familiar face within the new clinic that you're going to move to. You need a really robust paper process or text or email process, whatever you do, because I can tell you what, between the 3-month clinic appointments, that young person will have changed their mobile phone number at least twice. Okay, so you really have to have ways of getting in contact with them. And you know, there is good evidence from other chronic diseases that youth-friendly services really make young people feel much more welcome. And actually, you know, transition can be a really positive event for young people. So, you know, this was a young person who said, I don't feel like a child, I get treated like an adult and my opinions are valued. Okay, and actually transition can be we have so many negatives, but it can be a real positive milestone in a young person's life if well managed. And if we look at sort of the way research has to go, is transition programs, we don't know the answer within a setting, an individual disease state, we don't know what's transferable. So what we really need is to look at robust outcomes, looking at population health, looking at the patient experience, and checking that it is cost effective. So, you know, it's a long journey for many of these young people, but it is one that can be a very, very positive step. And, you know, they're incredibly inspirational, working with young people. You have an enormous amount of respect for them and for the journey that they have followed. And this is going back to our young Romanian orphan. There is me, the very proud clinic granny, holding her second child that she's had with her new partner. And, you know, she's got to the age of 27. She's on darunavir monotherapy. She's met a new, very supportive young man. You know, her CD4 count is now over 500, you know. So to conclude, the open door. I think we have a less than 2% lost follow-up rate in our adolescent clinic, of which we're incredibly proud. But if you ask the non-attenders what makes them come back, there is an absolute policy that you can walk in. You don't need an appointment. You don't need to text anybody. And there is always an open door. Even if you haven't been there for a year, you will be greeted with, how lovely to see you. I'm not even going to explore where you've been for the last year in reality. Because if you're greeted with, why haven't you been here? You haven't been taking responsibility. Why would you come back? None of us like to be shouted at. Okay, and it doesn't help. It doesn't improve people's attendance to be, you know, to be punitive with them. And teenagers get enough, you know, through education and through social services. They get enough sort of, we call them in the UK, we call them ASBOs. Okay, one of my current young men has an ASBO such that he's not allowed back because of his behaviour into his community, so he can't access his GP. You know, we were talking about starting medicines, and he saw the dietitian taking some Ensure, which are like vanilla milkshakes, to another patient. And, you know, he said, oh, I'll take my meds if I have that. And I said, absolutely fine. An Ensure and a Triamec together suits me really well. And he said, yeah, it reminds me of when I lived with my mum, and she used to make me milkshakes. And this is a kid who's been in and out of youth offending. So it's about having some understanding and empathy of the complexities of their journey. Oh, I've turned it off. Oh, yeah, and this is just, yeah, cute kittens. But it's just that teenagers don't want to be different, okay? So whatever service you have, it has to fit in with their lives. They, you know, they're the most, everyone says they're the most rebellious group, but they are the most conformist group in society. But they're just conforming to their peer group. They don't want to stand out and they don't want to be different, and living with HIV makes that very difficult. And a lot of people say to me, oh, we can't do transition because of the, you know, the healthcare system. Well, you know, we generically made the healthcare system. If it doesn't fit, then you have to fix it, then you have to change it. And that's our responsibility, because there is no point as paediatric providers producing kids, you know, up to 16, 18 or 20, and then them floundering in the healthcare system. And I'd like to thank a lot of people, particularly the young people who I work with, who just say it as it is. Thank you.